Good afternoon, everyone. My name is Kenneth Romero. I'm the Executive Director of the National Hispanic Caucus of State Legislators, headquartered in DC, and I'm also a partner of Pfizer's Multicultural Health Equity Collective. So thank you, everyone, for being here this afternoon. Before we begin, I want to provide some context to today's conversation. According to the World Bank, half of the entire world's expenditures on healthcare are spent here in this country. And we are only 5% of the world's population. So let that sink in for a moment. 50% of the medical resources go to 5% of the world's population. Yet everyone in this room would agree that the results and the return on that investment is quite poor and unhealthy. Medicare and Medicaid are the healthy safe nets for our most vulnerable communities, the elderly on the one hand, and the poorest amongst us on the other. And in the case of the poorest amongst us, it disproportionately impacts people of color, as you very well know. So that's why today we're joined by three amazing experts who can talk about those perspectives, but that also bring along their professional expertise. We're joined today by Senator Gustavo Rivera, who's the chair of the New York Senate Committee on Health and vice chair of the National Hispanic Caucus of State Legislators Health Committee. Jeanette Contreras, Jet, project director of the Health Equity Campaigns at UnidosUS, formerly known as National Council of La Raza. And Daniel Dawes, executive director at the Satcher Health Leadership Institute at the Morehouse School of Medicine, which, as you know, is one of only two historically black schools of medicine in the nation. There's four. I'm sorry. Got it. Sorry. I stand corrected. Four.
If I didn't correct you, if I get in trouble.
No, I appreciate the correction. Thank you. So Daniel, let me start with you, because we need to, I think, first tackle the elephant in the room. All the time we're talking about social determinants, economic determinants, genetic determinants, environmental determinants of health. But what has really been driving the inequities in health and healthcare in this country?
Well, thank you very much for that question, and I love that we're starting with the elephant in the room. Let me just first thank Pfizer for having this really important discussion, and delighted to join my distinguished colleagues on the panel. So to answer the question, for me, it starts with looking at why the inequities that we see in our society are not an organic outcome. It's not an accident, right? It's not a coincidence why we see higher death rates among certain populations or worse health outcomes. But why? So as you mentioned, people have been looking at these multiple interacting factors, from social determinants to commercial determinants of health to economics, you name it. And we know that, yes, collectively, they have been driving and creating these structural conditions. But what's really been fueling, what's been instigating those social determinants of health and other determinants of health, right? And they are politically driven, right? Through political action or inaction. And if I may, I would just love to take us back in history for a little bit to make that argument, right? So if you go back 400 years, and I can start at 1619, although I'll start at 1641. I do believe it's a fair starting point. But in 1641, that's when you saw, after abolitionists were making headway, right, in their movement to abolish slavery, you then saw the commercial interests, right, wanting to maintain or sustain their business model of slavery, working with the policymakers at the time. They worked in Massachusetts first. They created the body of liberties law that codified slavery, right, into law. They then amended it later on when the abolitionists were making headway again in their movement to abolish slavery, to require that the offspring of these enslaved black folks were they themselves deemed slaves under the law. And as if that weren't enough, what do? They go about creating additional policies, right? Massachusetts, New York, Connecticut, Maryland, you name it, that actually prohibited Black or indigenous folks from being able to raise their own food, right? A critical social determinant of health, as we call it today. They were prohibited by law from being educated, right? They couldn't learn to read and write. That was prohibited by law. Again, another critical social determinant of health. They couldn't earn their own money. So it goes on and on and on. They couldn't move beyond a 1 mile radius, depending on the jurisdiction. We know movement is key to life, right? And to health. They had to have passes in order to move about freely, or lanterns if it was in the evening time. So you can see how what we consider the structural conditions in which all of us are born into, we live in, and we die in, that affect all aspects of our health and well-being, how they originally were instigated by these political. They were concretized in our structures, in our systems and communities over time by acts of policy or policy in action. So we saw that then being recycled from one generation into the next, the 1600s into the 1700s, into the 1800s. And we then saw Jim Crow rear its ugly head with a vengeance, right? And you saw the proliferation again of policies stifling Black and brown communities from being able to exercise their right to vote, to participate in our political process. We saw that, as we all know, racists are very creative people, right? And so as the civil rights champions in this country were fighting to ensure that the Supreme Court would actually invalidate laws that were explicitly racist on their face, you then saw a movement to create policies that were what we call in the law facially neutral, right? They weren't explicitly excluding a certain group, but they were devised in such a way that they would have the same effect once implemented. The Social Security Act, right, is one of those. The Homeowners Loan Corporation Act that redlined and yellow-lined America, right? We saw the Highway Act that created a 41,000-mile interstate highway. Again, what does it do? It's not that these communities, Black and brown communities, built their communities around this infrastructure. They were there to begin with, right? But by an act of law, Housing Act was another one, raised housing and displaced over 500,000 Black and Latino folks in this country. Again, you can see how these policies have created the structural conditions that have then led to the poor health outcomes that we see today. So for me, the elephant in the room is what a lot of us have been afraid to really put our arms around, and that is political determinants of health. This is not a partisan framework, but it is a reality, right? So that is this is how I think about it. And I think in order for us to move that needle of health equity in the right direction, we have to actually complete the equation. We can't just stop at the social determinants, right? We really need to go further upstream, complete the equation by looking at how they came to be in the first place. Because for every social determinant of health, there was a preceding legislative, regulatory policy, or some other ordinance that created those social determinants of health. So that, for me, is how I look at the instigators of inequities.
Yeah, it's the cause of the causes.
That's right. Fundamental cause.
Senator, or Gustavo. Can I call you Gustavo today?
You can indeed. The only people I demand refer to me as senator are people who don't like or respect me. So I say, no, you call me Senator Rivera.
We've been good friends for years.
Anyway,
so arguably, the biggest inequity when it comes to Medicaid is the fact that not all states, have expanded Medicaid to provide more access to health care for those in need. What is your view of the situation right now, and what recommendations do you have to provide more access to care? I'll start with Gustavo, and then we'll go down the panel.
So, first of all, that was a hell of a start to the whole conversation. Like, whew. And I only add one thing, and I think I think we need to talk about, and I'm going to throw it in the middle right from the beginning. And that is that one aspect when we're talking about health inequities, we have to have a discussion about how the current healthcare system is both structured and financed. And the notion that if we can do a lot of work, and we have done a lot of work, and certainly I'm going to talk in a second about some of the stuff that we've done in New York to creatively use Medicaid money to be able to address some of the health inequities. But I believe that if we do not face the fact that all of this is perpetuated by a system that has healthcare as a commodity as opposed to a right, it's going to be messed up for a longer time. It is much harder to get out of it if you have people who are benefiting from the denial of care, right? So I'm sure we'll come back to that. But in any event, in New York State, for example, there are ways in which we have creatively used Medicaid money. That we've used Medicaid funds that we've gotten from the federal government. There are a process that is known as a waiver process. So there's different waivers that, and I'm sure that we're going to talk about some of them, that allow for states, with permission from the federal government, to utilize the federal share in creative ways. And the state of New York has done a lot of that, probably more than any other state. Just a couple that I'll mention off the top of my head. There's one that just ended after an 8-year period that was called, that we refer to as DSRIP, or the Delivery System Reform Incentive Payment Program. And the short version of that is that we realize that, probably is the case for most Medicaid systems around the country, that the biggest cost drivers are hospitalizations and avoidable hospitalizations. So the goal, we basically went to the federal government and said, hey, can you give us the authority to take $10 billion that you send to us and spend it in a way that we actually, in a very targeted way, lower hospitalization rates among Medicaid patients within an 8-year period. And they said, we'll give you $8 billion. And we took that and then we used it in a very targeted way to actually impact by about 25% the hospitalization rates, like the avoidable hospitalizations in the Medicaid population. And obviously that is something that could certainly not only incentivize the expenditure of money in preventive care as opposed to chronic care, et cetera, but it ultimately not only cost us less money, but also created better conditions for the individuals that are there. And lastly, we've also, in the state of New York, we use Medicaid money for long-term care, including not only home care, which we've actually tried to figure out how to incentivize. We actually just raised the minimum wage for home care workers in the budget that we passed this year. But also we cover even long-term care in nursing homes or other types of facilities. But we know that that's going to be that has to be addressed because there is a long-term care crisis around the country. So those are some of the ways that we've used Medicaid money in the state of New York to address some of those health inequities that exist.
Jen, I'd like to hear from you as working for an advocacy group, working in turn with many organizations throughout the nation.
Yeah, great. So I think I'm going to give you a little bit of our Washington, D. experience. I would say perspective on this. So Medicaid expansion that has not happened in the last 12 states that have left to expand could have been done with federal legislation. So there was a provision within Build Back Better that could have done this, right, federally. Where we are now is in the 12 states that have, 10 states don't have levers like a state initiative or, so they'll have to go through legislation to pass it. But it's interesting to note, and I will just add that the red states, because it's political, the red states that have passed Medicaid expansion have done so through initiative. So the people really have the power to make the change to expand Medicaid. And if you look at like a state, Texas, for example, has the largest population of people that fall in this Medicaid coverage gap, right? If that state would expand, they would have something like 775,000 people included in Medicaid coverage. I mean, this is huge, right? So Texas is a state that already has really limited Medicaid eligibility standards. It has a high number of uninsured people. So, and if they were to expand the way the policies are now, the federal government reimburses 90% of the cost to cover Medicaid expansion adults. And then through ARPA, the American Rescue Plan Act, there's an additional 5% federal matching rate to increase that. So it really doesn't, it's like a financial decision that I think some states have taken to their advantage that really, all the states should adopt. There's no financial reason why they shouldn't. It's clearly political.
And if I could add to that too, so there was a study that was done by researchers out of UC Davis, and what they found was that those that expanded Medicaid, the states that expanded Medicaid, actually saw significant decreases, mortality decreases, right? They saw higher life expectancies right after passing or expanding their Medicaid programs. They saw the infant mortality rates declining, right, which is significant. And in some cases, with the limited data that they have been able to get, also maternal mortality decreasing, which for us in the state of Georgia and Mississippi in the South is a major, major issue, right? So it does begin with expanding Medicaid. I've been very concerned when we initially passed the Affordable Care Act. I thought, okay, based on past precedent, we knew that, with the exception of Arizona, most states had actually established their Medicaid programs within 3 to 4 years, right? Including those from more conservative states. This one does concern me. We're 12 years out, and we still have a significant number of states that refuse to expand Medicaid in light of the evidence, right? It would bend the cost curve. It would increase life expectancy. We just seen a new study come out, right, that says that those who live the folks in conservative states and where they have conservative policies. Whenever you live in an area with conservative policies or less egalitarian or less equity focused policies, have what? The lowest life expectancies, the worst health outcomes, right? So in light of all that, it really is troubling that we still have failed to expand Medicaid. We still have refused to pour the type of money that is needed to bolster reimbursement rates, especially for providers that are safety net providers, right? Like us at Morehouse School of Medicine, where we serve the sickest and poorest patients in the city, right? So that is extremely troubling to me in that respect.
So Daniel, what are some of the specific policy issues that have addressed, whether at a national level, state level, local level, would make the biggest impact on correcting systemic barriers to health equity?
Okay, so that's one of them, right, that we just talked about. But in addition to that, one of the major things that we have been focused on are the data gaps, right? So data we know is foundational to a lot of the work that we are doing in this movement to expand health equity. And what we were thinking about over the last 2.5 years was about how can we at the Satcher Health Leadership Institute at Morehouse School of Medicine, how can we actually make a dent, right? How can we improve the situation, especially in this once in 100-year pandemic, right? This 403-year epidemic of racism in this country. What can we actually do? And while we can't boil the ocean, we can boil our individual pots. So for us, it was data. We recognized going all the way to 1793 when yellow fever had struck the United States, that it's always been, from that time until today, the same groups of people on the downside of advantage and opportunity who are most negatively affected. If that is the case, we figured, let's look into why that's been. And what we realized was that researchers and policymakers and healthcare leaders were unable to get access to data in as close to real time as possible, right? So perhaps if we could correct these data challenges, we would see improvements. That's what we've been trying to do. We created a health equity tracker to connect the dots for healthcare leaders and public health leaders and researchers and others, advocates and so forth around the country. If we can do that, I believe, and if we were able to standardize the data, right? If we could actually collect, a lot of you may have been involved in We Must Count. Anybody remember that coalition at the beginning of the pandemic? I can't say. I saw a few heads. Yes. Okay. so that was actually created because we couldn't get access to data, right? We couldn't get it from certain municipal governments, from certain state health departments or local health departments.
Or it wasn't disaggregated.
Or it wasn't disaggregated, exactly. So we were pushing to collect it, report it out, disaggregate it at least by race and ethnicity, so we could do it. So that for me, if we could modernize our data systems, right? Across the board among the various agencies with CMS, HRSA, CDC, et cetera, if we could also incentivize the states, right, when it comes to data collection and standardization and reporting, my goodness, I think that would be a huge win. In addition to that, what we've also found is that in a recent report that we were talking about earlier, right, on the economic burden of mental health inequities in the United States, one of the biggest issues for us is getting Medicaid, depending on your jurisdiction, of course, getting our federal government to really focus on paying for these and investing in these wraparound services, right? So key among this for me is the social determinants of health that we've been talking about. CDC got an $8 million drop in the bucket to examine and to address and to give out grants to community-based organizations, to health systems and others around the country to start tackling this. 8 million. And that is nothing, right, when we're trying to address this issue. Hospitals have spent between 2017 and 2019 about $2.5 billion on this. We'd like to see greater investments by the federal government to address these social determinants of health. And then, of course, I'm an advocate for addressing the political determinants of health. And I think Nancy Pelosi's bill, you talk about Build Back Better, and I know in her version, she had put in there provisions that would bolster voting rights in this country, right? Because we all know that voting can mean the difference between life and death. I absolutely think more investments need to be made on the front end to ensure that people are able to engage in our political process and help design and influence the policies that impact all of us. So those are a few of the things that I think if we really tackled, that would help. And then let's not leave out the territories, right? I worked for Congresswoman Donna Christensen, so she'd be very upset with me if I talked and did not include Medicaid reimbursement and matching for the U.S. territories. We know they've been discriminated in Medicaid funding in that program. I think we need to make sure that we're looking out for the territories as well.
A lot of the migration from those territories has been
That's
precisely
exactly right.
because they know that they don't have access to that. But
Exactly.
all it takes is a $89 flight to Florida, and they can get it.
Right.
Yeah.
Exactly.
So Jet, we're keenly aware of the power of grassroots advocacy and the press on the legislative process, but how do we grow the capacity of community organizations and health advocates so that we have an even greater impact on health equity outcomes?
Yeah, that's a great question. I want to just add something to
Sure.
the list that that Daniel brought up, and one thing that we're really passionate about is expanding access to immigrant communities, immigrant populations. And so Medicaid, there's like a thread here. We're talking about Medicaid expansion. We're talking about these safety net programs that really care for our medically underserved communities. And so there are a few pieces of legislation that have been, proposed, and likely, if I don't know if we get a miracle and we, the Democrats win the Senate, we could potentially get something through. But as you can see, that in the state of Georgia, we're looking at you. But if we could get something like the HEAL Act or Lift the Bar Act, where we could lift that 5-year ban on lawfully present immigrants. Now, these are not even like undocumented. That's like a whole other bag of work that like states like New York and California are doing to provide coverage to the undocumented in their states. But lawfully present immigrants don't have access to Medicaid and CHIP. Well, most states cover CHIP for children. I say most because it still isn't all, right? I mean, that's sad to say that we still don't have that waiver in all of the states to provide Medicaid and CHIP for all children that are lawfully present that fall within that first 5-year gap, right? And so that is something that I think is really critical to mention, to add to the list of where we move the needle. Now, to cover our grassroots communities, and we want to say that just funding is like really important, but aside from that, it's really capacity building. We have to really try to network our community organizations with state and national advocacy groups, because sometimes community organizations are plugging day to day, in their communities, and they can't get their head up to like see how can I get help right from the national organization, from the state organization, the advocacy community, to come and help, and engage them and get them activated in the grassroots advocacy piece, right? And so they're the ones that we're, engaging to train them on storytelling, right? Tell your story. We would love to be able to give them data, right? If we can give them, data about their communities, they can use that data to inform the work that they do in the communities. There's so much capacity building that we could be doing, right? Providing them data, giving them technical assistance on how to win federal grants, federal monies, right? And then at the state and national level, advocacy organizations growing those networks so that they can leverage those partnerships to do more good work, so that's it.
Juliet said in a previous session, we need to count to be seen, and we need to be seen to be counted. So
Could I actually
Sure.
add to that too? So I love that last point that you just made, because one of the issues we've been dealing with, so I co-chair the Health Equity Working Group with the CDC, and one of the things that's been very surprising is that the agency really, the bulk of their funding goes to state health departments, right? And then they have the ability to divvy it out to the local health departments and whomever. Well, a lot of CBOs are unable to tap into those resources, except for the REACH program. Everybody knows the REACH program, right? It's such a critical program that helps with the CBOs. But that's the only real program, right, at CDC. So we need to do more to advocate that these agencies are able from the front end when Congress is developing the appropriations bill, right, and putting the riders on these bills and dictating how those funds are to be spent, we need to be very savvy in making sure that they are basically requiring, right, CDC, CMS, HRSA, and others to actually target funding for CBOs, right, for these community-based organizations that really are closest to the people and therefore closest to the pain, right, and are the ones that have been driving this health equity agenda in the community. So I would say we need to make sure we are advocating for this across all agencies, because it's quite surprising how very little, in the grand scheme of things, is being directed to CBOs.
Definitely. Gustavo.
I wanted to
Sure.
say I wanted to add something.
Of course.
Only to
Mr.
mention
Sutton.
actually that to be more specific on a point that Jet made, which by the way it's cool as, like that's a great freaking nickname. Cool as a Jet. One of the things that we did in New York, we actually and both of them came from my bills, which then got put into our state budget, is that we were trying to get the essential plan extended across the board to all undocumented people. We got it above 65. So 65 years or older undocumented people are now covered under the essential plan in the state of New York. And we also extended for birthing people postpartum care for up to a year, even for undocumented folks. So those are two things that we managed to get done in the state of New York that directly deal with, again, dealing with health inequities. But you were going to ask another question.
Yes. But thank you for adding. What are some of the specific Medicare or Medicaid issues that must be addressed to help improve health equity?
I kind of referred to them to one of them right there when I talked about those two things that we've done in New York. One, because we have to just acknowledge, and certainly I think that I would guess most people, if not everyone in this room, would agree that undocumented people are people, and that they're going to need healthcare, and that if we ignore that, they're going to, unless you believe that somebody that is sick and can't get treatment should die, well, we're going to have to pick up that cost. And that is obviously going to, when they end up in the emergency room for primary care, and we don't know how, not only how bad that is for outcomes, but how expensive it is. So that is one overall thing that I think we need to, that I think all policymakers need to realize. And also that, and I'll keep going back to this, that if we do not acknowledge that having an insurance-based system is at the core of so many of our problems, we're never going to get out of it. Like we need to go to a single payer system. Like in the state of New York, I have a bill called the New York Health Act to do that. In the state of New York, I believe that not only do we have the capacity to do that, but I believe we have an obligation in the state of New York, and I believe that we have a way to establish a model to do it for the rest of the country. And it is, and since we're a little bit closer to the end of it, it has become increasingly difficult to fight that battle. But I'm more than, I'm in the center of it, and I want to be in the center of it, because if we do not acknowledge, and Uncle Bernie says it all the time, whether you like the brother or not, he says this consistently, having a system that has insurance companies at the core of it, again, where we take medical care and we commodify it. In the state of New York, or in the country of the United States, it is true that you have access to the best healthcare in the world if you can afford it. So if you can afford it, the Mount Sinai's of the world, the Presbyterians of the world, they have whole wings for you, bro. But if you don't, and this was actually said in one of the panels earlier, that there was I believe it was a panel that was in here, where somebody who was talking about their own experience as a birthing mother, and then or they're basically like a different part of the hospital that deals with Medicaid patients as opposed to private payers, and that happens in institutions all the time. So I would say certainly thinking about how we expand care with how we start from the notion that healthcare is a human right, and how do we actually put that and make that into a reality. Certainly starting with undocumented people, but then moving more aggressively. And I would, I know there's not the call to action part, but I would tell each and every single one of you that as proactively as you can and aggressively as you can in your own way, just push towards having single payer in the country, because it's a long-term thing. It is going to, this is the reason why we have 50% of the total cost, because most of that doesn't go to care. It is expenditures in healthcare, but it doesn't go to actually care for people. It goes for profits, and it goes for administrative costs, and it goes to waste. It should go to care. So rant over, at least for the moment.
Thank you. Sure.
So in addition to the health insurance coverage piece and increasing access, two very frustrating challenges that we've had to deal with in terms of Medicare and Medicaid have been this idea of the intersection of quality, value, and equity, right? And one of my biggest frustrations, let's start with CMS, has been that that attitude of trying to just go after the lowest hanging fruit, right? Instead of going, to the most challenging issues that intersect with equity, quality, and value. So I have found it really interesting that for years, we've had provider groups and others who have pushed back on attempts to get CMS, to get Medicare, right? First to enact the equity plan for Medicare. But then that one was such a fluffy action plan. It really had nothing of substance. And I told Andy Slavitt that. He's a good friend. I like him a lot. But it was a very fluffy one. And so today we are still dealing with superficial solutions, right? And I'd love to see us move CMS, move Medicare to actually looking at how we can address that intersection, create the type of models, right? Those programs for healthcare that will help us drive equity. And then in addition to that, we've also seen, as we talk about this hierarchy of human value today, right? There is a hierarchy of chronic disease value in this country. And behavioral health issues have long been relegated to the bottom of that totem pole, right? So for us, it is so important that we understand Medicare has long in quality payment programs, right? And in others, they have made equity programs optional for providers. That should never be optional if you truly care about equity. They have made the behavioral health piece of that optional. Depression for the longest has been the only thing that folks have had to really take a look at. I mean, we need to, when you talk about mental illnesses in this country, my God, they run the entire gamut. We need to do a better job being inclusive of these behavioral health issues that impact all of us, quite frankly, and many people in our communities. So I just wanted to add those two pieces. That's very important.
Unfortunately, we're still living in the age of COVID. And I think that what COVID has done is really display the intersectionality of the social determinants of health and access to care. So I wanted to ask you, precisely, Daniel, what are some examples of policy solutions that address that intersectionality of systemic barriers and challenges to racial health equity?
I go back to what I said earlier, which is what we saw Nancy Pelosi and others trying to put together. So Ways and Means Committee staff, the Energy and Commerce Committee, the Education, Labor, Senate Health and Finance had all done, I thought, a fantastic job as they were developing the BBB, right? Build Back Better Act. I thought they did a fantastic job creating a very comprehensive and reticulated policy around these systemic barriers. They looked at it not only from the social determinants of health lens, but from a political determinants of health lens. And what we have seen as they were crafting many of these provisions was an attempt to help us bolster basically bolster the diversity of the health professions. We saw, policies or policy provisions that were included in those that would have helped us and have helped us actually in the CARES Act and in, oh my God, I'm forgetting the American Rescue Plan, ARP, yes, thank you. So in ARP and American Care, and then the third one, they included provisions that helped institutions like ours, right, to be able to fix our infrastructure issues, which was a major issue with HBCUs and other safety net providers. They gave us opportunities within those bills to expand our class sizes, right, to expand our research facilities. And what we were able to do during COVID was to also tap into those funds to create programs, culturally competent programs for our community, right? Because we are an anchor institution in our community. We are the ones who, quite frankly, when folks were pushing this negative falsehood around the COVID vaccine, they looked to our scientists, they looked to our physicians, they looked to our researchers because they trusted us, right? They knew that we actually care about our communities and we have their best interests. So I think those policies enabled us to really mitigate the impact of COVID-19 in communities of color, especially here in the South. And in all of the communities that we worked closely with UnidosUS on our National COVID-19 Resiliency Network, along with tribal nations right throughout the country and the U.S. territory. So I thought those were pretty effective. I'm just sad that, you know, a lot of those provisions that Nancy Pelosi was pushing, unfortunately, did not make it in the Inflation Reduction Act. So we still have more work to do.
Definitely. So I have another question regarding COVID, and this goes to all panelists. So as a result of the stress and isolation people experience during the COVID response, as well as the direct and vicarious stress from the racial unrest and hate that was happening simultaneously, there is a lot more focus on mental health. What are some of the policy solutions that you've seen work or show promise for addressing mental health issues or other prevalent disease states that could be replicated?
Yeah. So first of all, like during COVID-19, our healthcare workforce took a hit. So the physicians are tired, the nurses are tired, mental health professionals are tired, people are leaving the profession. So we now have a workforce diversity issue that, like, you know, it's twofold. First, we need to increase the pipeline of physicians coming into the workforce to begin with, and then focus on diversity or training for cultural competency, right? So that we have the workforce in place to treat the communities that are hardest hit by COVID. And so, I think that that's really a priority, is helping to, what can HRSA do to help increase the diversity of pipelines? But another lever we can think about too is, can insurance companies be held accountable for the provider networks that they provide, right? If they're covering so many people, that means that they have to hire more physicians. They can't, we cannot wait 4 months to get to a doctor. We're in crisis. We can't wait 4 months because there aren't enough providers in our network, and we all don't have money to go out of pocket. I know I don't for my son, so I have to wait 2 months to get an appointment to get his ADHD medication renewed, so all of this, it's like very real to people who even have health insurance, that provider shortage, like physician shortage, is an equity problem.
Medication shortage.
Yeah. So yeah, the issue now is that, we're recognizing that we have a diverse population and we have diverse needs, and we're starting at a deficit already.
So while I'm working on the single payer issue, funny you mentioned, because I actually have a couple of bills related to network adequacy in the state of New York that are gonna tell me, don't tell them, but that we're looking to put some more teeth into the laws that already exist in the state of New York related to network adequacy, because health insurance companies try to do that all the time, and the impact that has is, surprise, surprise, outsized in communities of color. I would say everything you said about, I would double underline everything you said about workforce. That is an enormous issue. We see it across the board in the state of New York, and we're having a lot of conversations about both how do we strengthen careers with people who are in the career right now? How do we make it so that they don't leave? How do we create bigger pipelines from educational institutions? So we're having how do we forgive them their educational debt, etc. Like, we're trying to figure that out, because it's obviously something that's happening across the country, but we've seen it in a big way. And to address your question directly, Ken, I would say telehealth, expansion of telehealth, or just making the changes that became necessary during COVID to make them permanent. And many states have already gone a long way towards that. We in New York need to do a little bit more. I have a couple of bills related specifically to expand. We've already done it in a couple of fields, but we need to expand it far more. I think we need to make some of this stuff permanent, because what we found out was, certainly during the pandemic, it was absolutely necessary, because if not, there were some people that would have never had access, period. But we also found out that it made it possible for certain folks that, now that we've gone to back to some sort of normalcy, it does provide some access to folks that didn't have access before, by maintaining, not only by creating those telehealth pipelines, but by also making sure that the institutions that provide the care, there was somebody from HQHC earlier who was talking about this, that they had the issue in their state, and it was definitely in the state of New York, where FQHCs were not getting, had all sorts of issues about reimbursement of telehealth visits, and you're like, yo, they're providing their FQHCs, they're providing care to the most vulnerable, and you're shortchanging them while they're going out of their way to continue to provide care to these communities. Come on, man, don't be a dummy. So I would say that as well. Telehealth, expanding or making the telehealth changes permanent.
Thank you. So about 22 plus years ago, Dr. Satcher, right, when he was Surgeon General, issued the nation's first Surgeon General report on mental health. And what he stated at that time is as relevant today as it was back then. There is no health without mental health. So I'm so grateful that you included that question in this, because we know brain health is critical to our systemic health, right? It's one of the reasons why I actually brought this with me today. It's a report that we issued a few weeks ago looking at the economic burden of mental health inequities in the United States. And what we wanted to do is fill this really important gap in the behavioral health research and in our health equity research, right? Where we're building upon the great work that Brian Smedley and the audience had done in 2009 when we looked at the economic burden of racial health inequalities in the United States, but we hadn't included the mental and behavioral health components of that, right? So what did that cost us? How can we complete the picture? Because the reason why this is so critical is we know that in this country, we have never been able to advance equity-focused health policies unless you can demonstrate the government investment value, right? You can show that there is an economic argument to be made for including and passing and implementing and enforcing this provision, or there's a national security argument to be pushed, right? It is that argument or those arguments why we got 62 health equity focused provisions in the Affordable Care Act. Right? It wasn't because President Obama and his administration cared deeply about it. We got pushback. I know Brian was involved in these efforts. We had to, in order to stay at the table and push this health equity agenda, we had to demonstrate that national security and economic argument. And so in doing that, it is very clear, and this is where my students, when they hear me speak, they're like, oh God, this is so frustrating. They believe that the moral argument should be sufficient alone, right? That 83,000 African Americans die each year owing to disparities. And I said, you know what? You got me there. I'm a bleeding heart. But let's be quite real. There's a reason why there's a dearth of mental and behavioral health policies in this country and investments in this arena, as well as health equity focused policies. So until we realize that, it's going to be critical. So if I can just, I know I'm very long-winded, but I'll try to wrap up. The report, what we found was that from 2016 to 2020, we basically chose that time frame, modeling it after Brian's report back in 2009, right, that 4-year period. We wanted, and it was the time when we got the latest data in our hands, what we were able to show was that in that 4-year period, almost 117,000 people lost their lives prematurely owing to mental illness in this country, right? And it cost us $278 billion. 278 billion, and that's an underestimate. That's based on 4 data sets that collects this data that we could get our hands on. We know the problem is even worse. And so as we are moving forward, you heard me talk about, you know, the prioritization of behavioral health in this country. I do think we need to advocate at all levels of government, here locally, where they have jurisdiction over those type of policies, and of course we do in this area, the state as well as federally, to make sure that everyone, right, has a fair opportunity to reach their full health potential. So just wanted to add.
Definitely. And I want to comment on what you were saying about advocacy, because I'm based in Washington, D.C. Oftentimes, unfortunately, we have to be prepared with 2 sets of talking points. 2 sets of talking points, right? And to your point of your students, right? Like, if we don't, we're really denying that there are political determinants of health, and we won't be able to get across the finish line. So we have to play the game as well.
Got it.
If I may, as the only elected but somebody who before was elected.
Yes, Mr. Senator.
Yes, you can call me Gustavo. It's fine. But as somebody who before and elected was an organizer, and I continue to be, for me it's really simple. There's 2 ways to get something done in politics. You either show them the light or turn up the heat. You got to be prepared. You got to be prepared, certainly, to educate people. And there's some folks for whom the moral argument will eventually get to them and be like, you know what, you're right. And this is something that I need to put my political will into. But if they don't, you got to be prepared to turn up the heat. And that's where the organization, the organizing in your particular communities comes from. So those are the 2 things. And I say this as somebody was like, I tell people, demand more from me. Demand more. I don't know if the New Yorkers here, but demand more from me, damn it. From all of us.
And that's a perfect segue to what I wanted to ask Jet. So Jet works with UnidosUS, which is really one of the leading voices and advocates in the nation, and represents many organizations that are working directly with the communities. So Jet, can you give us an example of one that really has made a difference in tackling health disparities amongst Medicare and Medicaid recipients?
Yeah, thank you so much for the opportunity to highlight one of our amazing programs. And, we're talking about capacity building and community groups and how important that is to really addressing health inequities. We have this program at Esperanza Hope for All, which for the last 2 years has been increasing vaccine confidence in the Latino community, so much so that we've now achieved parity with the white population in terms of like the Latinos.
Say it again.
Because this model works because we're using our community organizations. Those are the trusted voices in the community, doing these messages, doing the outreach. They are setting up what our organizations, our grantees, thanks to CDC for funding with it, but our grantees and our affiliates have set up pop-up clinics, all across the country. They have done all of the partnerships, all of that organizing, the spirit of organizing they've used to leverage partnerships with the pharmacies, with the universities to do vaccinations, and they're doing both COVID and flu, which are, as we know now, are both really, really needed. I'm a big proponent of vaccine preventable diseases. If we can vaccinate for all the vaccine preventable diseases, we wouldn't have to talk about things like measles and polio anymore, like we're doing now.
I hope this example serves as an inspiration to many of you in the work that you're doing. So I have other questions I wanted to ask, but we wanted to open it up to the audience for Q&A. So please, I think we have a few hands up. So let's start over here. Oh, I'm sorry. Okay, we'll go. Yeah.
Community-based organizations and how they can be fortified to do work. Our organization, we're a family-focused organization, and we've never tried to run the CDC because it sounds so laborious until no end. My question is, where are the programs out there? Is there something to work with community-based organizations from a capacity building perspective? Because I have friends that call me, they want to grab the grant, and I'm like, you got to get the infrastructure. So it's starting at ground level zero with a number of these organizations that people that are just doing good things like us, who tied with our organization in order to provide services in the community. So where are those services? Yeah, they can put together. Is there a Pfizer initiative? Organizations like that, it's critical, they're needed, and in Mississippi we see the same old players who at some point put an intern in one of your offices someplace was able to garner.
Not mine, madam.
Relationship, but not necessarily doing work.
Okay. There's several questions. I'm going to ask just one of the panelists, so please go ahead. Chet, you want to go ahead?
I guess I will. Yeah. Well, the federal government does, I think, do some level of outreach and engagement and education around capacity building to help folks be more, I would say, to have more resources to be more competitive in winning a federal grant or federal monies, right? But there is an opportunity for all of these grant monies, and even the Pfizers can write this into their grant opportunities so that it directs the money go to a community-based organization. It's as easy as putting 2 sentences into a grant or funding opportunity, and leveraging your partnerships to build the networks for that. Because like you're saying, that it's the same people getting the grants. Well, it doesn't have to be fighting for the scarce resources when we should just level the playing field.
So, and I just wanted to quickly add to that because that is absolutely an issue that we are tackling right now with CDC, because we're trying to look at what HRSA has done. So some agencies have done these intermediary zones. Rhode Island did a health equity zone, and they're sort of serving that capacity too. They have maybe 1 or 2 organizations that are there to help. others apply for these resources. So I don't know of any really established that is doing this. I know you all, Brian, I believe had done some stuff with RWJF, with your organization in the past. Perhaps that might be one that could help. So you may want to talk to Brian Smedley afterwards.
Yeah.
You might have some. Brian,
Very good.
could you raise your hand so they can see you? I hate to put you on the spot, but
Okay. We have a we have a question here,
Good.
and then in the back.
So the first step is considering making more grants directly to community-based organizations. I know there's some of those that they're working on as we speak. So check out grants.gov to see what opportunities are here. Every CEO does not have to have a 501c3, so I think there are a few more opportunities opening up, so definitely look out. So I also had a question for Daniel about the CMS health equity strategy. Just wanted to know your thoughts on it. We were talking about, how some things have been done but not in a substantive way when it comes to health equity, particularly in this moment. I'd love to hear your thoughts.
Can I edit that question and ask you, what is the one thing, if you could just one thing, had the magic wand and could change one thing about CMS, what would it be? One thing, right? I'm just condensing it to like, woo.
Well, let me tell you, I am very pleased with what? Oh, so yes, I am very pleased with what Chiquita is doing with CMS and LaShawn McKeever, who leads Office of Minority Health and Health Equity there. Very pleased with their new plan and what they're focused on. If I could do one thing, change one thing, it would be getting CMS to focus on investing in pilot projects, right, around health equity. They have not done a good enough job investing in these pilot projects and making sure that we look out for organizations that haven't had that relationship with them in the past, right? The same go-to organizations time and time again. But investments in pilot projects around creating these models, demonstrating its success, and then scaling them up.
There you go.
That would be it.
Thank you. We have a question over there, then we have one here, and then over here. Okay, over there in the corner.
Well, thank you for that question too, because here in Georgia, that has been a fight for us, right? We have been fighting to get community health workers, promotoras, peer supports to be included in Medicaid reimbursement. It is always an uphill battle. We have struggled to get them to understand. So we get folks who fight back and say, well, they're unlicensed folks, right? We can't reimburse for that. So we're having to go, trying to go over that hurdle to help them understand the role that community health workers and all these, the navigators, the promotoras and others play in our health ecosystem. That's first and foremost. So we have not done a good enough job, I believe, convincing our policymakers in the state to do that. I don't know nationally, what others have done and been successful. I don't know if our colleagues.
Yeah, the short version is yes. Certainly in New York, that is, we are very much cognizant of, particularly as it relates to cultural competency. These folks are incredibly essential, and we have them in. There's a lot of sub-programs, if you will, all across the state. I mean, we're a large state. We have a very large, diverse population, and we have certainly we do reimburse for that.
I'll just add that it can be done through a state plan amendment, not necessarily a waiver. So it is really a state by state basis, and many states are now already have legislation to certify community health workers.
Any states in the South? Texas and Kentucky have?
Arizona.
Wow,
Like the Texas and the actual like the tech.
We have a question in the back.
I would love to hear how Texas did that.
Yeah.
I have only read it. That is not my area of expertise, Brandon, so I'm not sure, other than I'm sure it may have an impact, right? But I don't know exactly how. That's not my area of expertise.
And I would just say quickly, not being a federal legislator, I haven't given it that deep a thought. Uh,
Okay. All right. So we have 2 more minutes, and I just want to make sure that we get in 2 more questions. So we have microphone over here, and we'll conclude right here.
I've seen such great change. So I wanted to ask you your opinion as far as gentrification, how that can also affect health access, health care. In addition to that, I have witnessed low-income communities transform, and then instead it was the need for housing is small percentage available.
I-
Therefore, a lot of persons have been moved out. And so I wanted to ask your opinion on that.
I'm gonna have the senator answer since he comes from a
Uh,
low-income community in the
I do.
richest city in the nation.
Yeah, and one that has been, for a long time, we've been able to avoid the evils of gentrification. What I strive for in the communities that I represent the Northwest Bronx, about 320,000 folks. Currently, before my district changes, median income is about $30,000 a year in New York City in the 21st century. So you can kind of imagine. And the neighborhoods that I represent mostly have been able to avoid the evils of gentrification, and the things that we're trying to focus on are what I call inclusive development. Like as the changes happen, if there's things that are benefiting the community, they should benefit the folks that have stuck around. But as far as like what my opinion is messed up, and it's just another part of the evils of gentrification. It's like you make a place, friendly to folks that can afford it. Like you make it you make it completely unaffordable for the folks who live there as you modernize it, etc. And then obviously newer healthcare access comes along with that. So what's my opinion of it? I'm like, this is a PG rated panel,
Yes.
so I can't tell you what. Just ask me later. Just
All right, we'll conclude here. Okay.
single payer.
Yeah.
We do it like Canada did it. Like we turn up the heat, but we did it in Canada. Canada did it one. They started in Saskatchewan, so they started in one province and then it went to other states. We started in states, and that's why certainly I'm in a friendly, and I love to be in a friendly competition with California, because if they can get it done before we can, I mean, I want to beat them, but I'm glad that we're in that competition, because if a state establishes that we get it right, and I am in no. And I'm not, I'm not dumb. I'm not thinking that unicorns are going to fart rainbows and everything's going to be perfect. But the notion that we can go towards a system where it actually is built around the idea of healthcare as a human right, and that we can excise insurance companies and have them no longer making decisions about healthcare, like that's a world I want to live in, and that's a world that I'm willing to get politically attacked every goddamn day over. Like I'm so we do it at the state level first, and then we break through. Blah! Rant over for now.
All right.
That's cool. I scream and louder than they do.
All right. Well, I'm told that we've run out of time, so I want to thank Senator Gustavo Rivera, Jeanette Contreras, and our good friend Professor Dawes for being here and joining us for this conversation. This is unscripted, but I just have to say, because I have it right here, I really encourage you to read this book if you haven't. He didn't ask me to do this. This has been one of the most eye-opening books that I've read in the last few years. The Political Determinants of Health by Daniel Dawes. Encourage you to read it. It's just an eye opener, and it's going to really transform the way in which you're advocating for your communities and the way that you're having an impact on those communities as well. So
And buy it at your local bookstore, not Amazon. There you go.
thank you, everyone. Thank you.